So thank you everybody for attending. I'm going to do my best to make this at least a little bit interactive. I know in the virtual world sometimes that can be challenging. It would help me just a little bit if any of you feel comfortable doing that. If you would just type in the chat and let me know your name if you feel so inclined, but your background, your profession background, and maybe how many years you've been a member of the ethics committee so I can sort of get a sense of who's in my audience. That would be terrific. So today I am going to hopefully talk to you about what it means to build a moral community, how you think about building resilience as members of an ethics committee. It is interesting that prior to the seminar, I was talking with somebody about when people call the ethics committee, they're not having a good time. They need somebody's help. There's almost always a tragedy involved. And so it can be easy sometimes to get lost in all of the sad and difficult situations that we get exposed to. And I hope that what I talk to you about today is going to help you think about your role. Thank you for typing that. I really appreciate it. All right, so I have nothing to disclose. My time has been donated to further the work of the Center for Practical Bioethics. I have been an admirer of their work for many years now, and am grateful for the opportunity to partner with them on this particular topic. So these are my objectives. I don't typically read my objectives to people because I'm convinced that you can probably read them better than I can, but I am going to spend a little time talking about moral distress, talking about what does it mean, what resilience, how that looks at it. And so here we go. So I decided, since you all are members of an ethics committee, I thought I would ground my comments in how I think about what ethics committees do, sort of their functions. So you probably all know that you serve an educational role. You get to provide education, hopefully to help people think about ethical challenges, to give them some tools, sort of preventive ethics. If I think about it, it's sort of the proactive way of tackling this. You do policy work, you probably write, review, and make sure that everything's up to speed from a regulatory compliance standpoint. I also tell people that people don't typically look at a policy manual until they have a problem or a question, and then they look to the manual and they hope that it can provide answers. So I know, certainly in my case, we have had instances where individual ethics consultation cases come to the attention of an ethics committee because there's an opportunity to write or address a policy as a result of that. And then of course, case consultation. Many of you are called when there's an individual patient situation that people are concerned about. So typically the single most frequent reason our team gets contacted is when a patient or a family is receiving treatment that likely offers no further benefit, and it is considered either potentially inappropriate treatment or futile treatment. But it typically is around issues of death and dying. I tell people all the time that ethics is more than death and dying. It's just sort of one of the hardest things that we do in healthcare. And so people always want to make sure that they're doing the right thing. So another important grounding, I think, for this discussion is what do we do in ethics consultation? So this is a American Society for Bioethics and Humanities definition, probably not unfamiliar to all of you. So it's a service to help individuals address uncertainty or conflict regarding value-laden concerns that emerge in the course of patient care. And I also read that, I don't typically do things like that, but I read it because nowhere in that definition do you see the words fix it. And yet many times people are calling us because they think we can give them the right answer, and we can sort of help alleviate the distress or the stress that they're experiencing because we have the magic answer or magic wand and we can fix it. And in fact, we can't. And this is just a reminder to all of us that we need to remind people that we can't fix things, but we will do our best to help facilitate responsible decision-making in clinical practice, certainly for the cases that they're, the reason that they're asking for help. So when I think about moral distress, I actually have come to realize that I need to spend a little bit of time talking about what it means to be a moral agent. So you see a definition here. There's more than one, but basically, when you think about being a moral agent, it's about being self-directed, about having the capacity to make a choice for the actions that you're going to take. When I think about how do you get your sense of empowerment when you think about your role in doing ethics consultation? So typically it comes from codes of ethics. So physicians, nurses, social workers, chaplains, even lawyers, everybody, all of those different professions have codes of ethics that guide who they are and what they do in that role. And then we actually have a code of ethics for ethics consultation. So there's something that sort of lays down what it means to be a good physician, nurse, social worker, or what it means to be to do good work as an ethics consultant. So when I think about that code of ethics or those codes of ethics, it sort of grounds us in the values and goals, the things, the rules that define, give us boundaries within which to operate. So thinking about being a moral agent, it actually requires some practice, and I do mean practice, of self-awareness, including how do I be accountable to who I am, to what it means to hold integrity in my role. And so I've started with moral agency because for me, moral distress is actually inexplicably linked to it. So I'm offering up two different definitions for moral distress. The first one is one that I used in an instrument that I created, and I provided it for a reason on purpose. I'm actually going to make use of the instrument, so I thought it was important that I ground it that way. So moral distress is a complicated construct. It has been around actually for quite a long time now. We have not agreed upon a single definition. Many people are trying diligently to explain it, to clarify it so that it is possible to both figure out how to address it, to do research on it. So I want to make a really important point for me, and that is if you're experiencing moral distress, it doesn't mean that you are in fact correct and that someone else is incorrect in either the actions that they are taking or something that's happening. Likewise, if I claim to have moral distress, it doesn't provide evidence that I have moral privilege over anybody else. It's an important thing, and it is a very personal thing. When you think about the elements of it, as I'm trying to distinguish, am I having a type of distress or am I having moral distress? These are three pieces of moral distress that I think about. Certainly there's an emotional response, that's the distress. And the moral comes in when you think about the judgment about the morality or the ethics of a particular situation. And then part of the challenge of distress, certainly in moral distress, is whether or not you choose to act. So there's a behavior assessment, if you will. So this experience of moral distress is really grounded in your individual sense of responsibility to act in a particular way in a particular situation. So lots of times people will make judgments about the ethics of a situation, and their judgment may be flawed. Their judgment may be based on lack of information. And so, well, I have not yet put it in writing. Part of what I have come to think of when people say I have moral distress or can you help with moral distress is moral distress is what the person says it is, and your best response is tell me more. Because you have to explore why they think it's a moral issue and help them hopefully see something different or seek clarity or be firm in their perception that there is some sort of a moral challenge at stake, and their need to act is guided by their integrity. So when we think about the significance of moral distress, as I mentioned, it's been around for a long time. We actually do not need any more studies that tell us that people are experiencing moral distress. This is certainly one of the outcomes of the pandemic. It has exacerbated moral distress for many healthcare workers. And how do you know you have it? Well, you will have physical symptoms like any other excess stress. You might have headaches, stomach trouble, diarrhea, sleeplessness. All of those are things that have been reported in the literature. The reason I want you to pay attention to it, and the reason why I think members of ethics committees need to think about their obligation and responsibility to their organization when it comes to moral distress, is people who have high levels of moral distress report not just an intention to leave their current job, but in many cases, their intention to leave the profession. If you've been paying attention to the news, certainly in nursing, there is a hemorrhaging of people leaving the profession right now. The pandemic has taken a huge toll in many ways. So when providers have high levels of moral distress, there are also consequences for patients. We know that the care that's provided is more inconsistent. We know that the care that they receive is also less attentive. From an organizational standpoint, we know that if people have this intention to leave, that they're at risk for high turnover, which has a significant cost, both in quality of care as well as the bottom line. It takes 2 to 3 times someone's salary to recruit, hire, and train someone to replace a lost employee. And when you think about that for physicians and for nurses, that can have a significant burden to a healthcare organization. This is a diagram which I suspect for many of you is not unfamiliar. If you're members of ethics committees, you've probably acquainted yourself with this concept of what's the crescendo effect. This demonstrates a theoretical construct created by Elizabeth Epstein and Ann Hamrick. And what this shows is at baseline, everybody has a certain level of moral distress, and some event happens and they have this crescendo of moral distress. And eventually, whatever caused the distress in the first place, the situation will resolve and your distress will go back down. But often it doesn't go down to 0. And that may be because you had this distress and it dissipated because the event moved on, but you didn't actually figure out how to dissect or think about the nature of what was causing the distress. And then you go along happily for a while and there's another event and there's a spike and it goes down, but again, not to baseline, and you go on and on and on. So you can see this crescendo of residual, the leftover, if you will, when a situation's resolved. And you can see these moral distress crescendos. So one of the reasons that I think it's important for you to think about this as members of ethics committees, we've noticed this in our practice, and that is sometimes we will get an ethics consult request from a unit or a provider, and it seems like, haven't we had 5 of these in the last week? Or isn't this something that we know that they can normally resolve? And so the question is, are they experiencing spikes in moral distress because they have accumulation of moral distress? And so it's an important concept to think about. So what's the role of ethics? What do we do? First of all, I think we're really important. And you'll see the little highlight there is really deliberation, sort of to think about this. So there's a lot of attention paid to the emotional response, which is the hallmark of moral distress. And yet the experience goes much deeper than just that emotional response. So addressing only that emotional response really is just treating the symptom without addressing what was the cause of the problem. So that means deliberating or reflecting on the rules and the values that you hold dear and picking which ones carry the most weight and help you think about actions that you will take. So ethics really has the opportunity to bring reason and reflection on emotionally charged situations. You have to move beyond that immediate emotional response and reflect on how you've come to your opinion. And that's one way to clarify whether or not you have an appropriate belief about the ethically correct thing to do, or whether or not additional information can help you calm and think about a different opportunity. So basically, ethics should help you open your mind up and hear the perspective of others. And as members of ethics committees, sometimes that's your opportunity both to do it for yourself and to figure out how to facilitate and make it possible for people who are in a challenging situation to do it. So when you think about the ethics analysis, what are the pieces? Well, you identify the problem. So pretty much you figure out how to name it. You analyze it. You look at the values, the goals, the perspectives that guide what you should do. And then you explore, you imagine the possibilities. So some might say you look at, do the ends justify the means? Can I imagine what the ends are? Can I imagine what the consequences are for each of these different choices that I pick? So ethics is rarely black and white. For me, I always think of it as not gray, but technicolor, because people are usually emotionally charged in a situation. And that emotion makes it very bright and vivid, and it's very personal. So if you can name the conflicting obligations and responsibilities, then you can hopefully more clearly identify what the conflict is. And when you can identify where the conflict is, you should be able to name and identify the underlying values. So there's often more than one ethically permissible option, and clear choices may not always seem so clear. So how do I, in the midst of a morally distressing situation, figure this out. So Denise Dudzinski wrote a wonderful article and proposed an excellent strategy that I think is really beneficial for figuring out how to move past the emotion of moral distress and do the ethics analysis. And it's mapping moral distress. So when you're experiencing moral distress, the way that it feels is it's a threat to your core values. And what I've said to my colleagues is, if you say you have moral distress, that can no longer be enough. You have to be able to explain it, explain what you think or believe the correct action is, and what justifies it or how you came to that. So I'm going to give you a heads up because we're ethics and we always do cases. So I'm coming up with a case and I want you to be prepared to answer a poll question, hopefully. If you're not able to do the poll, feel free to type in the chat. So I just want to give you a warning and get ready. So the map is really a tool to facilitate the reflection, individual reflection, or a conversation if you're working with more than one person, to help you imagine different perspectives and more clearly see the underlying rules and values that have caused you to come to your conclusion. So using the map is hopefully going to help you to move past the emotion. So let's do a case because we like doing cases in ethics. So moral distress, is it? Is it not? When I do these cases, I'm going to ask you to rate your moral distress on a score of 0 to 10. And I hope you'll see that not everybody will experience distress in the same way or to the same degree. So Joe is a 29-year-old patient hospitalized for treatment complications related to his lung cancer. He is now COVID-19 positive, which likely is contributing to his respiratory decline. Joe appointed his mother, Jane, as his healthcare representative. He clearly told the chaplain and bedside nurse that he did not want, there's a missing word there, that he did not want to be intubated, even if he might die. He was very clear about that. Jane has not been able to visit in person, and when approached by phone about goals of treatment, stated she wanted everything done, including making him a full code. She is his legally designated representative. So some members of the team believe that there should be an exception to visiting to allow Jane to fully appreciate the situation. I am guessing that this is not an unfamiliar circumstance for any of you. So this is the case. And of course, somebody has called the ethics committee to weigh in on this. Can we please, we think it's unethical to not let Jane visit and she should come. So here's our story. So here's the instrument that I want you to use, Moral Distress Thermometer. You can see here, and Matthew, if you could launch the poll, that would be great. The stem of the question is, moral distress occurs when you believe you know the ethically correct thing to do, but something or someone restricts your ability to pursue the right course of action. So I want you to reflect on this case. Maybe you're the person taking the call. And if you could just indicate what your level of distress is with regard to our case of Joe. I'm going to see if I can figure out whether or not it looks like, I can't tell. Matt, you're going to have to tell me how people are replying. Do we have a good number? I'm somewhat competitive. I need the audience to know that. So I really go for at least 50%.
We're at 76% right now.
Yay, awesome.
And it looks like our peak is 64% of responses are at distressing 5 to 6.
Okay. Can you just share the results so people can see it? I want to see if we can, let's see if we can show them what it looks like.
Oh yeah, here we go. Share results. There you go.
All right. So you can look around and see that for one of you, you are alone, none. Now I tell people all the time, it's not, if your moral distress score is 0, then I have concern for you. And it's a different type of concern. And that is, in general, these situations are distressing. But if you know a clear answer and you think you know the right thing to do, that's okay. But I love the fact that there is a spread here. And so some of this is pretty distressing. If anybody, go ahead and close that, Matt. And we're going to sort of unpack this. We're going to have another poll question. So hang on. So what's your emotion? That's the first thing to do in our moral distress map. I want to know what your emotion is around this case. And for heads up, so go ahead and launch that, Matt. Heads up. If you're going to pick other, I'm going to invite you to share what your emotion is. So I don't want to discourage anybody from checking other, but I've put up just a list of common emotions that are associated with moral distress, and I'm very interested in finding out if there are other ones. So let's see if we can get 75% of people participating. That competitive edge.
12 of 13 now.
I discouraged people from putting other. That's too bad. That is too bad. I was really hoping somebody could give me another emotion to work with. So we've got frustration and sadness, anxiety, irritation. I noticed, so I did not give people the option of picking more than one. Some of you may have one. So not a big surprise that there is some emotionality of this. So I'm going to move to the next slide, and you're going to get to do another poll question so you can see how your colleagues are doing. So what's the source? This is where it gets really challenging. Is your source of distress related to Joe's code status? Is the source of your distress related to that visitor policy? Is it because of potentially inappropriate treatment? Is it a sense of powerlessness to help? Is it a concern for potentially early withdrawal or withholding of treatment? So if you could go ahead and launch the poll, Matt, let's see how people respond. I'm just curious about this. Silence is the death knell for rodeo and video, but it's an important silence.
One or two more.
All right, how are we doing? Okay, so we have different source of distress. For some of you, it's that visitation policy. Some of you are worried about potentially inappropriate treatment. Some of you're not, there's nobody worried about premature withholding of treatment, sense of powerlessness. So I'm going to ask the brave individual who said other, would you be willing to share?
We can share via the chat, or probably the chats would be easy.
Chat's probably the best. So I hope, or maybe you can enter it in the question and answer. The point is, different people feel the stress differently. The source is different for everyone. And the reason that matters is, if you can see what's contributing to it, addressing someone's concern about a visitor policy is a very different intervention than addressing someone's concern about their sense of powerlessness to help, or about their concern for potentially inappropriate treatment. So when you think about your role as an ethics committee member, first of all, identifying what your source of distress is an important thing, so you can set it aside, and then know walking into it that other people, like the source of distress, may be varied.
So we got a response here. It says a lack of understanding of the fiduciary duty by the agent. So the agent's lack of understanding of their fiduciary duty.
So what am I responsible for? What am I the one holding the bag? Do I have the power to control that? Thank you for saying that, because that leads me to my next point. Excellent. So when this is so there's a source, but how do I weigh how to think about this? So I'm supposed to support patient autonomy. I'm supposed to do good for patients. I'm supposed to avoid unnecessary harm. I'm supposed to treat patients with dignity and respect. I'm supposed to support all these policies. And how can I do this when sometimes these obligations and responsibilities seem to be in conflict? And this is really, I appreciate if anybody else wants to type in the chat any more things that they can think of in terms of conflicting obligations and responsibilities. And this is one of the things that I appreciate a lot about Denise Dazinski's work, is identifying what is it within your scope of responsibility, what is within your scope of control. And that is one thing that I think many people get lost in, feeling much like they call us as an ethics committee to fix it, particularly if it's an unfixable problem. If you think about, can I identify, am I really responsible for this? And if I have raised a concern, so let's say with the chief medical officer about an exception for the visitor policy, is does my responsibility end if the chief medical officer says, no, I can't make an exception? Do I then have to push harder? Can I be satisfied with where I think, have I exercised my obligation to the best of my ability? So when we think about this challenge to engage in ethics work, again, nobody's going to call you when they're having a good time. You will probably be distressed. Typically, when you hear the first request for help, you're hearing one side of the story, and it is not uncommon for people to become distressed or easily be empathic and feel and align themselves with the person who tells the story first. So one of the big challenges for all of us in ethics is remembering that we're only hearing half the story first. It is really an important thing. So even if we think we know what the correct option is, what would be consistent with our values and goals, we as members of ethics committees have to figure out, where do we sit here on this? So when we talk about moral distress, there are barriers to taking that action, that final step. Sometimes they're internal. Maybe I just don't have a lot of confidence. Maybe I'm unsure about what's my fiduciary responsibility. How far do I take that? And then there are external things like, what is the organization's policy? What is the charge of the ethics committee? What is our scope? Some ethics committees navigate strictly patient-focused events. Some ethics committees also deal with professional standards challenges, somebody behaving badly. Some ethics committees are housed in a risk environment. So knowing where your ethics committee fits and sits within an organization will help define what are the external constraints on you. Sometimes laws. Within many states, there have been state legislatures who have passed laws that will prohibit or restrict public health interventions for the pandemic. That's been a challenge. Maybe you're feeling a lack of support. All of those are things that could be barriers to you doing, even if you've identified what's the right thing to do, they will be barriers to you being, okay, I know the right thing to do and I'm not going to do it. One of the benefits of going through this map is it's one thing to feel that you can't do it and not address the barrier and feel distressed that you didn't honor your integrity. And it's another thing to feel the distress, go through the analysis, and intentionally choose not to act. That is one way to honor who you are and what role you play. So next, and I believe last poll, so I want to know, what should you do? What are you going to do here? So Matthew, if you could launch this poll question, these are some options for what you could do in this situation. You're going to tell Jane what Joe said. Maybe Jane doesn't know that Joe told people he didn't want this intervention. You're going to talk with Joe about his end of life wishes. You're going to tell the physician what Joe said. Maybe the physician doesn't know. Or you're just going to write a note in the chart, make a recommendation, and move on. And you know, what else could you do? So let's think about it. Let's give it up to 45 seconds. Let's see if we can get people to make a suggestion.
We did get one comment that said, from Carmen, that says, there are so many sides to the patient's story, not just half, very complex. Sometimes listen to multiple threads.
Yep. Thank you for that, Carmen. That's actually a really important point. When you put up that little picture of the two scales, I haven't found a picture that has 100 scales like weighing in that picture, but that's what ethics people do, right? It is more than two sides to the story. Thank you for that.
Comment here from John that says, maybe the agent did understand her duties. She just felt that the patient wasn't capable of making an informed decision, e.g. clinical depression. Yep.
Maybe he's depressed. Maybe he's unhappy with being in the hospital. And all of these there are issues that come up. So let's see how people identified what they want to do, what they think they should do. So we have some great choices here. So now the bonus question, the bonus point. So some people, you know, you're going to tell Jane, and again, you may pick many of these, not just all of them. You're going to talk with Joe about his wishes. You're going to tell the physician. Nobody's brave enough to put other again. You've all figured out my trick. So, but here's the deal. We can stop sharing. And that is, what value or rule made you pick what you picked? So when a lot of you said, I'm going to talk with Joe about his end of life wishes, what was the value or the rule that said that was the right thing to do? If anybody could type that in the chat, I'd be interested. I know for me as a practicing nurse, good end of life care begins with understanding the patient's wishes, honoring patient's autonomy, begins with understanding what a patient wants, their preferences. And so coming in as a neutral person, sometimes for me, the rule, the value, I value neutrality, I value strong communication. All of those are things that would guide me to talk with Jack. So Matthew, if anybody else has typed anything in the chat, feel free to share that.
Yeah, we just got one here from Polo saying having fully informed patients, family members, and doctors is important.
Yeah, so this is, part of your role, part of your value is ensuring good communication, because that's how you facilitate discussion about this. Excellent, thank you. Move my mouse back. All right, so how do you deal with moral distress? What are you supposed to do with it? First of all, you may have it as a member of the ethics committee, and probably virtually everybody you're talking to is experiencing moral distress. So first, acknowledge it, certainly when you're feeling it. Encourage people to name it. It sounds really crazy, but naming an emotional response is a very effective way of disarming it. And then you're gonna need to get more information, right? You're just gonna need to find out more. Tell me more. Tell me about the nature of your distress. Tell me what your source of distress is. All of those things are important as members of the ethics committee. And then engage with other key stakeholders to learn their perspective. You sometimes, you saw the spectrum when I asked people, what's your range of moral distress? If you're an 8 and somebody else is a 2, you can say, help me figure this out. Or you're a 2 and someone's a 6, help me understand that. Learning others' perspectives is a way of gaining perspective on your own intense reaction, and also a way to figure out, why is somebody so calm, or why is somebody so distressed about this, and how can I think about it? Moral distress may represent, more than anything else, a lack of meaningful discussion about what's happening, about being in a stressful environment and not being able to talk about it, not knowing, can you talk about it? So still deal with it. I want to make this a really important point. Moral distress is not a character flaw. Moral distress is not a sign that something unethical is happening. But in order to deal with it, you have to think about it on an individual level, and you have to think about helping others at their own individual level identify how they can think about it. And then there's a team. You're working on a team. Sometimes a team is an inpatient hospital team. Sometimes it's an ambulatory care environment team. Sometimes it's somebody out in the community. But the fact is, you very rarely work in isolation. And so dealing with moral distress means you're going to have to think about what's going on my team. How am I, if I know that it could be that we have a lack of meaningful discussion, what's our barrier to that? So how do I think about enhancing my skills to raise really thorny questions on my team and with other people who frankly may not want to be asked really thorny questions? So in an organization, we know that in my experience, high levels of moral distress reflect systems challenges. Maybe it's a resource issue, maybe it's a leadership issue, could be any number of things. Maybe it's a regulatory compliance issue, any number of things. But we know that when people experience moral distress, it's very rarely in isolation of a systemic problem, whether it's how call schedules are set up, or what resources are available in the off hours. And so when you think about how am I going to intervene with moral distress, I have to think about this at an individual level, a team level, at an organizational level. I will also say that the healthcare system, I think many of us now recognize painfully that the healthcare system in the United States is broken. We don't have equal access. We have problems with equity. And so to be a part of a system that is so broken represents some distress, and we all who work within the system have some kind of an obligation to think about how can we address that problem, how can we make it better. So back to emotion and reason. When I said a lot of people focus on this emotional part of moral distress, and addressing your emotion is how you take care of yourself, which is a really important thing to do. Stress management interventions, mindfulness is something that a lot of people have put a lot of energy in. And I'm going to talk about resilience. But when you think about reason, what does reason do? Reason brings focus to the emotion, and reason, applying reason to these situations, it's what's going to help the patient, because ideally it's going to help us identify ethically permissible paths and be able to make clear recommendations about what are appropriate things to do. So enhanced communication skills give providers, healthcare workers, something to do when they find themselves in these ethically challenging situations. One of the things that I have found is, I hear people say that they can support a plan that's inconsistent with their values if they believe that the patient, and I think one of the comments actually said that, a fully informed patient with capacity can make this choice. As long as I have all the information and I have discharged my responsibility, so if I'm a physician, if I have done adequate informed consent and they know what they would want to do and they're choosing it freely, they have capacity, it may not be something I would choose, but it is something I can support. That comes from the ethics analysis. That doesn't come from just helping you feel better about your distress. And that's why this Dzinski map is, I think, a really essential tool. So what are we going for when we do all of this? So there's this emotional part of your brain. Some people call it the lizard brain because it's intuitive, it reacts instantly. And then there's the reasonable brain, which is logic and processes. And when you're looking for wisdom, you're looking for how logic can be informed by the emotion and come to a decision that recognizes the distress and still is able to help people sort through what are reasonable or logical alternatives. So in my work, how do we do that? One of the things that I have become a big believer in, both because of the clinical work I do and the research work I do, is members of ethics committees can play an important role by learning how to facilitate conversations about ethically challenging situations. And that's different than doing an ethics consultation. This is sort of how do we informally help people do this? So how do we create this open space where people who disagree, who feel vulnerable in raising that voice, can be safe and share it? And then what we know is if you can create this space where people can hear different points of view, then you can enhance participants' abilities and their confidence, frankly, in dealing with these challenging situations. So I know from my research that people who participate in facilitated discussion around ethically challenging situations, their moral distress goes down. And that's actually not where I think the focus needs to be. What we've learned is their moral agency, their ability to make a judgment about the ethics of a situation and identify a barrier and choose to overcome the barrier or work around it. Their moral agency is enhanced. So people who participate in these discussions are more likely to observe and participate in and even initiate those difficult conversations, which, if you think back to what I said about moral distress may be a sign of a lack of open discussion, that's a good thing. So I want to share something with you. When our program at IU Health is called Unit-Based Ethics Conversations, and we call this the GRIPE model because the woman who created it is Amanda Gripe, one of our past ethics fellows. It's not because people are griping. But so when you're trying to talk to people about an ethically challenging situation, there's usually a lot of emotion swimming around. And the way to get out of and past emotion is to name the ethics issue, focus on it, let people sort of hear about it, and then invariably there's more emotion and you swim around for a while and you name this ethics issue. And then you summarize at the end of the discussion, you highlight the ethics things. And that is a way to sort of help people see and move through this ethically challenging situation. And this is what we've learned. When you have open discussions, if you as members of the ethics committee, both within your own committee meetings, as well as what you can foster in the community outside of your ethics committee, if you can create an environment, people learn from it. We know that there are a lot of senior people who have wisdom to share, a lot of junior people who may be shy to speak up and think, oh my God, I'm the only one. It builds a sense of community, which is really important. I'm going to talk about that. And then there's just psychological benefit of this. Oh, I'm not the only one. When I asked you each to rate your level of moral distress, you were able to see, okay, I'm not the only one. In one case, it was one person, but still there's this sense of I'm not there. And when these three intersect, this is what we see, is this sense of enhanced moral agency. So this is just identifying some research that shows peace rounds, pediatric ethics and communication excellence, ethics huddles, facilitated ethics conversations. All of these are examples of interventions that have been shown through research to lower moral distress And we think it's because it's enhancing moral agency. So what strategies can we talk about for building resilience? I will say I have two definitions here to offer you resilience. One is straight up resilience and one is moral resilience. There's a lot of time and attention being paid to resilience as a strategy to address moral distress. And I caution people that it is an incomplete strategy, although it's one that it is hard to argue that it's a bad thing. So like moral distress, there is no one unifying definition of resilience or moral resilience. Whatever the definition, it really is a capacity that requires a supportive environment for flourishing. In other words, I can be resilient up to a point, but I can't be resilient forever without supports around me to rejuvenate me. So shared values and mutual support in teams, including support from leaders, are really key elements of how you build the sense of resilience. So these are some features of resilience. We have, these are defined by the authors here define it. And I came across something that I want to share with you because I think it's important. So the Rushton Moral Resilience Scale, this is an article that was just published in 2021. They've created a scale to measure resilience, and with the goal of building on, can we come up with a definition? Can we figure out how to measure it? Can we create these interventions to help restore people and be resilient in ethically challenging situations? So how do you respond to moral diversity? This is, in earlier literature, this was referred to as being buoyant. In other words, being able to support yourself, this sort of self-regulation. What's your sense of personal integrity? And that's maybe independent of what your professional integrity is. So what do you think defines you in terms of your wholeness? And how do you stay true to your own personal values? What does integrity mean to you? There's moral efficacy, which is, do I have confidence in my ability to respond to this ethical challenge? Can I navigate this moral conflict in a way that's going to reflect the values that I hold dear? And then this relational integrity, and that has to do with distinguishing my own from others' views. I hold my values, and that goes back to, can I see others' perspectives? I wouldn't choose what that patient chose. They're different values. I can hold my own, and I can respect the other person. That's relational integrity. All of those are things that we look to in terms of, can I do this both within my committee as an ethics committee, so that I can be rejuvenated, become buoyant and resilient, and go out and help others outside who are in the midst of ethically challenging situations be resilient. So this, oops, I'm sorry, I think I messed. My slides are out of order, but I'm just going to tell you, does anybody recognize this? This is Bozo the Clown. When I think about being resilient, this is what individual resilience is all about. You would hit Bozo and he would be knocked down, and then he would bounce right back up and he would keep coming back. And that's the emotional piece, but Bozo never figured out how to duck when I was trying to hit him. And so that's the ethics analysis piece. So if you think about resilience in and of itself, that's just Bozo. It's not enough. So how do you think of yourselves as what is called a community of practice? A community of practice is really a group of people who share this common interest. Members of ethics committees typically do that. You have tacit knowledge, you meet regularly, you have a goal with what you do. So you really are trying to build your community of practice. In an ideal sense, you would be collaborative in your work. You would share and create knowledge with what you do. You would promote and share your identity among, what does it mean? How do I walk proudly and say, I'm a member of an ethics committee and this is what I do? So Delgado is the author et al. They're the authors that sort of propose this. What does it look like to have this community of practice, and what do you do? So having some mutual trust. And if you have this community of practice, this community resilience, not just independent resilience, it allows you to think together. It allows you to restore your own moral integrity and sort of build this collective moral resilience. This is sort of working together. When you think about an approach of communities of practice, it recognizes that systems and organizations have this responsibility towards shaping the working environment in a way that supports ethical practice. So somebody chatted earlier about fiduciary relationships, fiduciary obligations. For some ethics committees, their charge is simply to address, to be reactive. And for others, they have a charge to be proactive and to work toward creating this community of practice, expanding on the work environment. So when you establish this community of practice, it's really a process. It doesn't happen overnight, and it does take intention. So members of a community practice allow each other to share their ethical challenges and choose inquiry or curiosity, right? Exploring over this just emotional frustration. So how do you create a moral community? How do you do that? Well, here are some suggestions. In the end, it's really about all of us working to create a community that's focused on what's best for patients and how we do that. It's being committed to engaging in difficult conversations. It's learning the language of ethics, not just so that I know it, but so that I can help others know it. It's knowing how to manage, not resolve conflict, but really how to navigate and be around it. What I know is that we may be open to the acknowledgement that we work in flawed systems. It's not perfect. And it's not our job to make it perfect. That goes back to what's our charge, what's our responsibility as members of ethics committees. But it really is our opportunity to help make it better. So you can work in a challenging environment if you feel like you're on a team of supportive people. So this is a resource that I encourage you to explore. It's from the American Association of Critical Care Nurses and Standards for a Healthy Work Environment. The three that I have highlighted here have to do with skilled communication, ethical decision-making. Those are hallmarks of healthy work environments. And it's essential for ethical practice. It's essential for navigating ethically challenging situations. And if you can't fix the system, you can at least work to establish an environment and a team that works together. So unlike Bozo, this is the picture that I have in my mind when it comes to thinking about what is a community of practice? How do I build resilience? And I'm not going to do it alone. So if you look at these skydivers, and I will say that I downloaded this picture from the internet many, many years ago and cannot find the attribution. So if anybody can attribute this, please tell me, because I would like to acknowledge it. I'm not trying to violate copyright. It's just a beautiful picture of teamwork. So you can imagine that these skydivers didn't just say, hey, let's jump out of a plane together. They had a plan, they had conversations, they resolved their disagreements, and still they're working together. So when I think of a moral community, this is a place where people can raise their concerns, and it can be treated as an opportunity to grow together as a team. So you build your team with intention. It takes work and it takes effort, but everyone engages in discussion to resolve the conflict, not to minimize or shut someone down. So members of a moral community really feel free to explore emotionally charged situations and help others think about it. So I'm going to invite comments or questions. I have put my email up there if anybody should have any questions. And I hope that you have gotten a sense of how I think about moral distress for ethics committees, that we've had a little opportunity to explore what it means to have ethical communities or moral communities, and then thinking about building resilience. So I see Matt is back on the screen. So I'm hoping you have some questions that people have, and I'm hoping to be able to answer some of them.
Well, I'll invite people to submit questions via the Q&A tool. It might take a little moment for some of them to get submitted. You can also drop comments in chat if you like. Got a small graphics glitch here. One moment that, or one thing that kind of occurs to me while we're thinking about this is just the importance of having kind of like predefined strategies, or sort of like almost like protocols, ways that you know how to address these kinds of issues before they occur, right? So you the importance of like not just sort of being overtaken by the frustration or the distress, but knowing that it's like, oh, when I feel this way, these are the steps that I take, right? And just how critical it is to have kind of like a playbook already established. And
so when you're a member of an ethics committee, and let's say you get a call from someone, if you're having a bad day, or you find yourself getting really fired up, it's really hard, but that is the best opportunity to go, wait, time out. Where's my distress? What's causing it? And how do I back up so I can best intervene to help people. So one of the things that I'm going to say, I was actually thinking about this a lot. Could I offer a really concrete strategy? And while I'm hoping to get more questions, I want to offer this one up because it's so simple. And it's something that I failed to do early on in my career when I was a clinical nurse specialist. Never undervalue the importance of getting to know people, of just everyday chit chat. So it's a strategy. If you look it up, it's called appreciative inquiry. So one of the things that, and people who have to suffer through meetings that I facilitate know that I'm famous for asking just a random question. So people just get to know something about people. Yesterday's question for one class was, tell a funny story about a bad clothing experience, because I had a bad clothing experience that day. And it was hilarious. And so being intentional about getting to know people. And if you don't believe me, Atul Gawande was interviewed many years ago, and I heard him talking about, his checklist manifesto, and he kept saying, I really wasn't a big believer in this, and then he did it, and it actually worked. And so he talked about a very simple strategy that he uses to increase the likelihood that somebody is going to interrupt a surgery and call a timeout or point out an error. It's a very simple strategy. So think about people in the OR. The only thing you can see are their eyes, right? Mask. At the beginning of surgery, he asked everybody to introduce themselves. Just the leader of the team says, "Hi, my name is, and please tell me who you are and your role." That increases the likelihood because you've essentially invited people to be not invisible in that little group. So it's just a simple strategy.
Yeah, it's interesting because you're immediately aware of the two-way street there, right? That everyone knows who everyone else is, right? So there's like now there's something at stake. There's like a mutual stake at what's going on. Yeah, yep. Interesting. We do have. Oh, go on.
No, I was going to stop sharing, but then I realized my email's up there. So you want me to stop sharing, or do you have a preference?
Yeah, I think you can stop the screen share. We've just got some questions rolling. And I got one here from Polo that says, what do we do with conflicting ethical judgments on a particular situation or case?
Well, you could act like Solomon and just cut.
Yep.
I think it's the naming it that we don't all agree. And for me, the essential strategy that I've always used is time limited course of one path. You've got to pick one and always agree that we're going to try this at least for a period of time, and we'll come back and revisit it and see if there's a different way. So I'm not sure that answers the question, but when I hear what you were asking, Matthew, that is what I would say.
Yeah, I'm struck by kind of how important it seems to be to be like working alongside the other people in your moral community, right? Like when we were looking at the kind of the suggestions on how to build it, it's like you recognize that like, oh, all of these things could be accomplished by like working shoulder to shoulder on a project or something like that, right? Like this kind of like figuring out how to communicate with each other and stuff.
So I'm gonna presume that the person who asked the question is also thinking about the situation. What do I do when the other side is wrong? And I know they're wrong and they're dead wrong and I can't do it. And I like to follow that path would violate my integrity. So the answer to that question is really uncomfortable. Sometimes you get to make a choice between being on the path and not rocking the boat, or choosing to, in some cases, leave an organization. In some cases, to sign off of a case. That's the point where you get to, where is my line in the sand? Where does my integrity lie? And as bad as this is, I know and believe that if I stay silent now and follow the path, I'm investing in a future. I'm not going to rock this boat because the ship's already sailed, but I know that this is going to inform what I'm going to do next time. And I can choose to live with it. Or you can say, this is the 5th time it's happened and I can't keep doing it. And in order to preserve who I am, I'm going to walk away. And that is why some people leave organizations, because, maybe the other path really isn't right.
Investing in a future is like a really concise, like sort of framing there, right? Because you end up like, no matter what you end up doing, you're investing in a future. So you have to like figure out which one you're comfortable, like which future you're comfortable ending up in.
Yep.
And like, no, it seems like knowing where your line is also probably a good idea just in general, because you'll know if you're south of it, you're fine, right? Like,
Yeah.
we can work through this. If we land somewhere south of the fine, we can work through this.
Yep. I'm going to presume that silence is not a bad thing, and there's a minute to go.
Yep.
There's a minute to go.
Yep.
So I want to thank people for attending. I hope they found something useful, and Matt's going to have some tie-up things to do for the business end.
Yeah, and thank you, Lucia, and thank you, Ryan, for being on the call today. Let's see, we're coming up on 1 o'clock here, so I just want to remind everyone that we record these sessions, and we'll get the recording posted to our YouTube channel. You can go to YouTube and search for Practical Bioethics. You'll find our channel there, and you'll find the list of episodes in this series there. If you want to review any of the content or share it with your colleagues, we encourage you to do that. And then also, before we sign off, I just want to say that this is going to be my last episode of the Ethics Committee Consortium webinar series, and it's been a great opportunity. I've really enjoyed putting these together and working with all the great scholars and colleagues and members of the kind of Ethics Committee Consortium and community in Kansas City. So I just want to thank everyone for that. And there's exciting things in the future for the consortium, and I hope everyone enjoys it. So with that, I will go ahead and sign off, and hope everyone will make it to the next one. So,
Thanks,
have a good rest of the
Matt.
week.